I was just terrified by the previous presentation of William Evans, not because of poor quality, but because it was just saying exactly the same things I was expected to say without previous agreement. So the first temptation to me was to catch my plane back and to disappear. However, I will try to provide a slightly different perspective, which is the perspective of the geriatric expert group, which is illustrated at the bottom of this first slide. We have been working with the commitment received by the CHMP in EMA to set a document on the definition of frailty and on the possibility of using frailty as either a selection or a stratifying measure in randomized clinical trials in older adults or in studies in the post-registration phase. We worked by telematic methods with the coordination of Francesca Cerreta and their invaluable help. Frailty, the definition is a multifactorial syndrome caused by a reduction of physiological reserve, or in other terms, the homeostatic capacity to face and to cope to stressful events. It is associated with an increased risk of unfavorable clinical events such as disability, hospitalization, institutionalization, and even death. It is a condition which is complex and dynamic. To describe this condition, several models have been proposed, and the geriatric expert group has reviewed all the proposed models and made some choices which have been introduced in the document. The challenges to me to solve with the topic of frailty is how can frailty be practically measured in clinical settings, and we will make our proposals. The second challenge is, are frailty measures useful to predict hard outcomes independently of comorbidity and/or disability? Today, in particular, many of us have been speaking alternatively of comorbidity, disability, functional limitation, targeting all these different domains under the common umbrella of frailty. To the geriatric expert group, this is a prerequisite for adopting measures of frailty in randomized clinical trial. The third challenge is whether frailty itself is a potentially relevant outcome measure in randomized clinical trials. In other terms, is frailty a modifiable entity with, for example, defined exercise intervention? Let's move to the first challenge. As Williams has anticipated, Linda Fried and co-workers defined an operative model, an operative definition, found an operative definition of frailty using the data of the Cardiovascular Health Study. And this approach to frailty, as have been already said, is particularly focusing on sarcopenia in terms of reduced strength, reduced gait speed, increased tendency to exhaustion, reducing physical exercise. According to this model, a phenotype frailty index is divided and stratified into 3 levels: frailty, intermediate or pre-frailty, and no frail or robust. The model has been already presented in another graphical form, converge towards a reduced muscle strength and muscle mass through a complicated pathophysiological path involving largely pro-inflammatory cytokines. What is interesting, that is the only item not already illustrated, is that according to this model, frailty is a dimension which is relatively independent of disability and comorbidity. And my next part of the presentation will focus on the demonstration that exploring frailty adds something in the assessment, global assessment of older patients with definite disease. An alternative model of frailty proposed by Rockwood, which I dropped very rapidly, relies mainly on the definition of comorbidity and functional limitation. And indeed, with this approach, frailty is largely contained in the dimension of disability and comorbidity, without a net separation between the three different domains. This is another illustration of the short physical performance battery, which derives directly by the Linda-Fried model and consists of 3 items: standing balance, walking speed, and 5-chair standing, providing an overall score ranging from 0 to 12. This, to our opinion, to the opinion of the geriatric expert group, represents a practical mean of measuring frailty in a potentially useful clinical dimension. Now, let's move to the second challenge. Are frailty measures useful to predict heart outcomes, independently of disability and comorbidity? The first demonstration has been already provided before, and is a demonstration that using the short physical performance battery score, one can predict incident disability, BADL disability, in older individuals who were not disabled at baseline, proving again that disability and frailty measured by this approach are 2 different dimensions. The second demonstration is that frailty, again expressed at the short physical performance battery score, predicts long-term mortality in general older population, even adjusting for comorbidity, the index of coexistent disease, age, sex, and mini-mental state examination score. So this proves that frailty, again measured with this approach, is different from comorbidity and adds explained variants to the general model of predicting mortality. This is a demonstration that short physical performance battery can be fruitfully used in a practical clinical setting. The short physical performance battery here have been assessed in a series of patients with chronic cardiac failure admitted to acute care hospital for the increasing severity of their cardiac failure. You can see that it separates nicely the prognosis long-term, and in a multivariable model, the short physical performance battery is highly predictive of the risk of long-term mortality, even after adjusting for comorbidity, the CRS scale, and 2 disease-specific indexes in cardiac failure, such as left ventricular ejection fraction and the New York Heart Association functional class. Again, the gait speed is nicely separation in post-cardiac surgery older patients, the risk of dying with a cutoff of 0.83 meters per second, even after adjusting for the Society of Thoracic Surgeon risk score. Frailty in this study has been used to identify patients who could profit the most by an intervention, an exercise intervention, compared to a control group. And you can see that the disability score of those randomized at exercise intervention drops down, whereas in the control group, it increases, suggesting an increase in disability level. Can frailty be used as a potentially relevant outcome measure in randomized clinical trial? The first demonstration is that the short physical performance battery improves together with an increase in walking speed in older subjects, which in the life study was randomly assigned to physical exercise compared to control. The conclusions which the geriatric expert group is proposing to you is that frailty defined according to the Linda-Fried model, predicts nicely clinically relevant outcomes, such as incident disability, death rate in the general older population, but also in chronic conditions that are common in older persons, such as chronic heart failure. The predictive value of frailty is independent of comorbidity, disability, and disease-specific severity index. Therefore, a frailty measure following the Linda-Fried model, and in particular with the use of the short physical performance battery, can be used as a different dimension in order to stratify population and to adjust for results. In randomized chronic health trials, frailty proved to be either a valid selection or a valid outcome measure. And we are convinced that because of its independent prognostic power, measures of frailty with use of the short physical performance battery could be proposed as an adjustment variable in pre- or post-registration pharmacological trials in older persons. Thank you.
Thank you very much. Any questions?
There.
Yes. Yes.
I'm a thorough geriatrician from Austria. There are other dimensions to frailty also that are being described more and more, and that make the definition a little bit more difficult. The psychosocial dimensions, how do you account for those?
As I demonstrated, for example, the mini-mental state examination score was tested in our series of chronic heart failure patients admitted to acute care hospital, and it was put out from the model when it was included the short physical performance battery. The idea is that we have to find out summary variables incorporating different dimensions and accounting for a general frailty. Because it is obvious that the more complicated is the minimum data set that you are defining, the most difficult is, in practical terms, to use this data set to account for in randomized clinical trials, particularly out of the geriatric departments. I think it is a compromise between specificity and sensitivity.
Yes. Dr. Evans?
Yes, I agree. I think you can expand the definition of frailty to be whatever you think that it should be. It could be those people that have a low socioeconomic status, or it could be those people that have a low mini-mental state. But I think if we assume that poor functional capacity ultimately is the common denominator, and the final common pathway for changes, there are all of those things that we think contribute to that poor functioning, and that's the thing that we need to treat. Now, all the low functional capacities, they may have many different causes and many different treatments, but I think that one way of identifying those people is important. The really important thing, I think, is that all physicians, all geriatricians should have a functional measurement as part of their standard treatment and evaluation.
If I may add a few words, it is obvious that you have also to take into account the idea that frailty definition must be assumed to have an ecological dimension, because it is obvious that if I am defining frailty in acute care hospital in bedridden patients during a very acute or severe conditions, I cannot use the short physical performance battery to assess frailty. In that case, a surrogate of frailty might be comorbidity or the level of disability 1 week or 2 weeks before acute admission. There is another question.
Yes, Elizabeth?
I would like to come up with a practical proposal, because I think we all agree that frailty is not a diagnosis, it's a syndrome. And for years, we have very good experience with the metabolic syndrome. We have to have 3 risk factors out of 5, and then we can call it metabolic syndrome. I think we in geriatrics, we should come up with a solution like that, and then to make our experience and collect data, and then maybe time by time we can make it better or more specific.
Sure. Anyway, the geriatric expert group has proposed to the CHMP the adoption of the short physical performance battery as a measure of frailty to be used either to stratify the population and to adjust for as a potential powerful confounder to adjust results in post-regulatory studies, but also maybe in pre-regulatory studies.